One more question, if somebody out there's got one more question.
Sorry, was that another question?
One coming.
Hi, Keri.
Okay.
Karen Anderson from Hospice Care. I was just wondering if I heard you correctly when you said that increasingly palliative care specialists are taking a lead in the gold standards framework work.
Karen from Hospice Backing thinks you said that specialists were taking a lead in gold standards framework application.
Well, we've got my team of nurses, some of whom that you met within the GSF team, Simon, when you came. You know, some of them come from specialist palliative care backgrounds. We've always they've always been lead people for this because they can see how it enables better care. For primary care, it's really good to be owned by primary care. The same with aged care facilities, care homes. It's got to be owned by the group that it comes from. So we didn't want one group to sort of take over and impose. So the care homes work has been tried and tested and worked through with the care homes people themselves, the aged care facilities. So, but St Christopher's Hospice in London is our first regional centre. There's a hospice in Yorkshire that's leading this in the Yorkshire area because, you know, we're talking about the same thing. We're talking about enabling better care in a whole different sort of medley of ways. The hospices have played a very important part in this. I mean, we don't want hospice to exclude others or to de-skill others, and sometimes generalists can feel a bit de-skilled by people they think that know a lot, and they do know a lot. And but it's not. It's, you know, we don't want to be de-skilling, so we don't want to give a message that you know, you have to be a specialist to do this work. But it's a matter of sort of catching the same vision, really, a shared vision. And it's just been lovely. The last 4 years working with St Christopher's, they've been fantastic. And they've spread this around to every one of their care homes in the area. They really believe in it. They've really added to it. That's another thing. The hospices can, we do train the trainers and train up the people, you know, might be in the hospice, and they deliver the work, although often we've delivered. We've set up this virtual learning centre as well, so or setting it up so they can take the work. But then they can add other things like teaching about advanced care planning, discussions, communication skills, drug access, more symptom control. So they can add different bits which have to be more localised. So it's got to be complementary, and as long as we're sort of facing the same challenges together without and realising that things will only really work when we work together. The valuable role of hospices. I've worked in, I think, 7 or 8 different hospices myself. I've done, you know, lots of hospice work. For a long time, GSF, we based it in one of our hospices in Birmingham as well. So it's so much a part of what we do. But it's like the outreach from the hospice, from the walls of the hospice out into the community to make sure that patients in the community get good care.
Keri, if I may make a couple of observations, I think the framework itself has such integrity that it provides the objectivity that helps across the boundaries.
Yeah.
The second part is the style in which you teach or empower, rather, the teams to do this stuff is critically important so that they do own what they do.
Yeah.
They reinvent the gold standards framework within their own setting because that's what they feel is the best care.
Yeah. No, that's right. And I was saying to Joe, say I come across a stroppy group of GPs, which is pretty common, and lots of times they've done this, and especially a whole lot of people say, well, we don't want this imposed by outside, and if there's any kind of, you know, it's a real turn-off. You don't want something that's brought in by someone, not invented here kind of syndrome. So one of the things we do is get them talking about the kind of good experiences of care that they've had, and when it really went well, the kind of really bad experiences of care they've had, and what it would take to get from the bad to the good. And then they start practically re-suggesting some of the things that are part of GSF, and we'll say, yes, you need a communication form, a handover form, you need good means of identification and all those things, and we add them up and they say, yeah, this is how, and they reinvent GSF. But it's terribly important that it becomes self-motivating, I think. And I think one of the mistakes we've made, as it were, was pushing things down, policy downwards. You know, there's a balance between things being a grassroots momentum upwards and things become national directive downwards. And there was almost a tipping point with us when GPs were saying, look, if anyone tells me what to do, I won't do it. But if I know colleagues and peers are saying that this is a good idea, then we'll do it because it's what we came for. There's one GP who said, what about the day job? This is the day job. This is why we came into medicine in the first place. And it's lovely that. So it's a fine balance because you're trying to help people become so self-motivated that this is what they want to do and ask them questions. And that's where I've certainly learned along the way that we've got to watch out not to sound imposing.
Keri, seeing as I'm chair, I can ask another question. And as a manager, I just wondered, what are the costs to providers who want to embark on the GSF program?
Simon, is that what are the costs?
Yeah, maybe I can deal with that later.
Yeah. I'll just tell you, because the translation into dollars and things would be different, but for the care homes, it was roughly 1.5 to 2 weeks of one resident in a care home for the whole year training. That's how we kind of balanced it. And, so it depended a little bit on how many residents they had in the care home. The primary care thing was free. It was funded by the Department of Health as a change management right across the NHS. And then since then, other areas are commissioning a particular training program, and we try and work in groups of about 15 practices and offer some kind of support for that. So, and also, I suppose, if you're factoring costs, it's what needs to happen to get to first base and that kind of thing. But the cost should never be prohibitive because when you look at what we're trying to save, it's in our currency, it's about £300, £400 a day for every patient day in hospital, and £2,500 for an average admission, and then £300 every time you call an ambulance, and you just add up the costs, and let's look at how we're wasting money really, and how money could be better spent. So there's a fairly good, strong cost-effectiveness argument. I know St Christopher's have shown they've reduced hospitalisation from 45% to 30%. There's such a significant drop that it becomes cost-effective argument. But whether it's, who pays for that, and in our area mainly it's the larger groups. It isn't sometimes it's the care homes and GP practices, but mainly it's the strategic group above them, the primary care trusts or the others above them.
And as you know, Keri, it's winning the hearts and minds who are the commissioners, and then to have investment money to actually kick-start the thing that can be a real challenge, even though the philosophical argument has been won. Yeah, I know. We'll be having more discussions on that, otherwise I'll have nothing to say.
Yeah. So, Keri, we'll draw this session to a close, and on behalf of everybody here, thank you very much for giving us of your valuable time. And very interesting and informative. So thank you. And I think you mentioned early on that in the UK you were looking at a 17%, I'm not sure whether it was an increase or something or other following the Olympic Games.
Yeah.
Next year, well...
17% increase in deaths, yeah.
That will pale into insignificance if the All Blacks don't win the World Cup in October this year.
Well, I really look forward to meeting some of you. At the moment it seems so, if I'm just a little speakerphone on the table, or whatever I am, it'd be wonderful sometime to meet up with you, because we've had various conversations. But thank you for keeping up with the PowerPoint. Thank you, Joe. I hope that worked all right.
It's fine. Thanks, Keri.
Well,
thanks very much.
Ask everybody to thank you.
Yeah.
Hope the rest of the day goes well.